Hello, everyone. Thank you for joining us for today's event. It is 1:30, so we'll go ahead and get started. Today, we will be presenting Feeling Safe Enough to Hear It, communicating about injury prevention using a health equity lens and trauma-informed approach. For your information, all participants' microphones are muted today. If you have any questions, comments, or require technical support, we ask that you please use the chat box that's located in the bottom center of your Zoom Windows taskbar. During the discussion period towards the end, participants will have an opportunity to unmute and ask questions, or you can use the chat. As a reminder, this webinar is being recorded. The recording will be available on the Saskatchewan Prevention Institute website and will be emailed to you in the coming days. My name is Robin Stewart. I'm the Child Injury Prevention Program Coordinator with the Saskatchewan Prevention Institute. The Prevention Institute is a provincial nonprofit organization that is located in Saskatoon on Treaty Lands 2, 4, 5, 6, 8, and 10, and the homeland of the Métis Nation. The lands we gather, live, learn, and work on are deeply connected to Indigenous people who lived here historically and who live here now. We affirm our commitment to reconciliation through our work with the communities we serve. Our organizational focus is to help all children thrive through primary prevention and the promotion of well-being. We aim to raise awareness, build capacity, and respond to emerging trends by providing training, information, and resources based on current best practice. We believe that all children, regardless of ability, have the right to the best physical, social, and emotional health possible. We work in a variety of areas, including fetal alcohol spectrum disorder prevention, maternal and infant health, early childhood mental health, child injury prevention, child traffic safety, parenting, and sexual and reproductive health. The goal of the Child Injury Prevention Program is to reduce childhood injuries that result in hospitalization, disability, and death within the province of Saskatchewan. We aim to provide evidence-based information on child injury prevention that is accessible to service providers who work with children and families. Communicating about injuries and injury prevention can be complex. Using a health equity lens and trauma-informed approach can help us provide services that are safer, inclusive, and impactful. Here to speak on this topic today, we have Stephanie Cowell and Claire Westmacott from Parachute, followed by Erin Beckwell from the University of Regina. Thank you so much for being with us here today, Stephanie, Claire, and Erin. I will just ask before I do some introductions that we hold your questions for the end of the webinar when we will have a discussion period. So starting off, we will have Stephanie and Claire presenting. Stephanie has spent more than a decade working in the area of injury and trauma prevention. She is the Director of Knowledge Translation, leading the analysis and synthesis of research to develop the organization evidence-based solutions that advocate and educate. Stephanie's experience includes working with government, health, sport, and education stakeholders at national and provincial levels. Stephanie is skilled in creating spaces for facilitating collaborations. Stephanie is a speaker and presenter at conferences and workshops and is a media spokesperson on a wide range of injury prevention topics, public policy issues, and knowledge mobilization. Stephanie holds an honors bachelor's degree in sociocultural anthropology from Wilfrid Laurier University and a knowledge translation professional certificate from the University of Toronto. Claire joined Parachute in 2021 and manages Parachute's programs and campaigns that focus on injuries at home and during play, including poisoning, concussion, and fall prevention. Claire has worked in the nonprofit and public health sector for nearly a decade. She is experienced in knowledge mobilization, applied research, and program management, delivery, and evaluation. She is passionate about health equity and environmental health, as well as applying and improving effective communication and knowledge exchange strategies. Claire holds a Master of Public Health degree from the University of Edinburgh and an honors bachelor degree in environmental studies from the University of Toronto. We are so lucky to have Stephanie and Claire joining us today. Please go ahead when you're ready.
Thank you, Robin. I'm just going to share my slides now. Okay, so hopefully everyone can see that. And Okay, so hi everyone, welcome. My name is Claire Westmacott and I'm the manager of knowledge translation. And as Robin mentioned, today I'm joined by my colleague Stephanie Cowell, who's the director of KT at Parachute. So a quick thank you to Robin and Saskatchewan Prevention Institute for having us here today to share some of our work. And we're also very excited to share this virtual space with Erin and really look forward to the discussion after the sessions. We would also like to acknowledge the land on which Parachute is located. For thousands of years, it has been the traditional territory of the Wendat, the Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. Today, this land is home to many Indigenous people, and we are grateful to have the opportunity to work on this land. From coast to coast, we acknowledge the ancestral and unceded territory of all Inuit, Métis, and First Nation people who call this land home. We would also like to quickly acknowledge our funder for the Early On project, which is a project that we'll discuss during this presentation, the Ontario Trillium Foundation. So a quick word about Parachute. We are Canada's national charity dedicated to preventing serious and fatal injuries. And we focus on 3 key areas where people are unintentionally injured. So in the home, at play, and on the move. And through our work, we educate and advocate for preventing serious injury in our homes, in sports and recreation, and on our roads. We take a public health approach to injury prevention, driving evidence-based implementation-focused solutions that are innovative and meet the needs of our very diverse stakeholder and injury prevention network across Canada. And collaboration is a really huge part of the work that we do, and we are very lucky to work with many partners, including the Saskatchewan Prevention Institute, and to be a part of many networks across Canada connected to injury prevention at the federal, provincial, territorial, and local level as well. So today we'll be talking about the impact of injuries, injury prevention using a health equity lens, and we'll also be talking about lessons learned and considerations for practice, really leaning on specific examples of injury prevention education for parents and caregivers of children under 6, and some of the work that we've developed in that area. So I'll hand it over to my colleague Stephanie to get us started on the impact of injuries.
Thanks, Claire. And thanks again, Robin, for that great introduction. So, in applying our public health approach, of course, we first want to understand the issue of injury. And so we look to the most recent data we have available. And in 2021, Parachute released our 4th version of the Cost of Injury in Canada report, which quantifies the cost of injury using data from 2018. And we know that injuries are the #1 cause of death for Canadians aged 1 to 44, and the 3rd leading cause of death for Canadians overall. And what this translates to is every single day, 48 lives are lost across the country due to preventable injuries. We see 4.6 million emergency department visits due to injury each year. And this translates into a cost to the Canadian economy of $29.4 billion in a single year. And the majority of that, $20.4 billion in direct healthcare costs to our system. Now, when we look specifically at childhood injuries, and the figures on this slide, the next slide, please, Claire. The figures on this slide are showing data for children aged up to 14. In a single year, again, more than 14,000 hospitalized injuries and more than 800,000 emergency visits for injuries. And again, thinking about quantifying this cost, which is one of the measures that really speaks to decision makers and policy makers, the total cost of childhood injuries in a single year is $2.9 billion. Next slide, please. So overall, injuries, and specifically unintentional injuries, things like falls, burns, poisoning, are the #1 cause of death for children over the age of 1 in Canada. And a recent publication from Children First Canada, a report entitled Raising Canada 2022, looking at the state of childhood well-being in Canada, ranks injury as the #1 threat to childhood. And so it really is something that warrants public health attention, and something that we often see not getting as much attention as it should as a public health issue. And we're talking here about numbers and figures and even dollar figures, but we also want to emphasize that there are impacts of injury that we just can't quantify. So the impact of injuries on individuals, their families, entire communities, effects that are physical, emotional, psychological, and economic. And so we do want to also acknowledge, the pain and suffering and other effects that injuries have in our society. So next slide, please. In part of understanding the issue, we want to understand not just the burden of injuries, but also how injuries are happening so that we can target prevention efforts and supportive efforts. And so we know from the evidence that most injuries to young children occur at home. This makes sense. Children spend a lot of time in their homes, and homes are environments designed and built for adults. They are not built and designed for small children, though we can adjust them a little bit. But we have to be aware that homes are, spaces for learning and exploring and growing, but that's also the location where injuries occur. And we want to be aware of how do we make those home environments safe for that learning and exploring and growing. When we look at the types of incidents that cause injury, particularly serious injuries, so injuries that result in hospitalization and death in children, our youngest children under the age of 5, these are things like falls, various breathing incidents, so choking, suffocation, unintentional poisonings, as well as burns and scalds. Back to you, Claire.
Thanks, Steph. So child injury prevention is complex because the risks and causes of injury change as children age and develop. Several factors, including physical characteristics, cognitive abilities, and the degrees of dependence really affect child injury risk. And they also inform age-appropriate approaches to child injury prevention. I'm just stopping here. Okay, just to check the chat. People can see the slides. I can understand. Yes? Just want to make sure that everyone's seeing that. Okay. So for example, when we talk about the sort of interplay of these factors, falls are a leading cause of injury, hospitalizations, emergency department visits, and disabilities for children 0 to 14. But where children fall changes as they age and they develop. So infants and young toddlers typically fall around the home from furniture and downstairs, whereas older toddlers tend to fall while walking, running, or crawling around the house. And children 5 to 9 fall most often at playgrounds. And falling is a really normal part of development as children learn to walk, run, and explore their environment. And a crucial distinction that I just want to note at this point is that injury prevention is focused on preventing those serious injuries. So those hospitalizations and emergency department visits and disabilities and worst case scenario, those deaths. The sort of age-appropriate interventions that we need to take place without stymieing important aspects of healthy child development, which really do include play and exploration in those challenging and stimulating environments. And beyond the individual, consider that injuries are the result of a complex interplay of factors on a variety of levels. So injuries are not accidents, but really the result of factors that are embedded in the environments where people work, play, and live. And the evidence is clear that injuries do not affect all Canadians equally. So similar to other health issues, severe and fatal injuries are disproportionately experienced by individuals and populations who live in less affluent neighborhoods, have low socioeconomic status, and have low educational attainment. and the likelihood of experiencing severe and fatal injuries decline for every incremental increase in income and neighborhood affluence. And from the literature, we see that these disparities exist. So for example, an analysis of BC hospitalization data found that there are higher hospitalization rates for injury among Inuit, Métis, and First Nation populations. The Canadian Community Health Survey found different age standardized rates for injury in the past year according to sexual orientation, and respondents identifying as lesbian, gay, or bisexual had higher rates than those identifying as heterosexual. Injuries to people in rural areas also tend to be more severe, have a higher likelihood of being admitted to a hospital, and are more likely to be transport or work related. Lower socioeconomic status is also associated with a higher risk for major injury and injury-related death. There are a couple of exceptions to this that we see. Injuries in adolescents are consistent across SES, and sport and recreation-related injury generally increases as SES increases. And lastly, an analysis of Ontario Emergency Department data found that children and young adults at the lowest income areas are 40% more likely to be injured. And this is just a snapshot of some of the data that really demonstrates these disparities. So this chart here provides examples of factors affecting injury risk. Injuries are often attributed to the behaviors of individuals, when in fact there are a complex interplay of factors affecting injury risk that take place at the individual, community, structural, and social level as well. And this includes everything from social connectedness in the community to income support and childcare policies as well. And these factors combine to create the conditions in which people and children live, play, and work, and they really influence and shape day-to-day life. A lack of resources can mean increased exposure to hazards such as inadequate or unsafe housing and dangerous conditions in the community, such as poor road conditions or play infrastructure. It can also mean that individuals or families are unable to purchase products that can prevent injuries from occurring, such as baby gates, bicycle helmets, or winter tires. And the experiences of social and material deprivation can result in a great deal of stress for families and can contribute to feelings of anxiety, sadness, and hopelessness. In addition to the negative impact that chronic stress has on physical and mental health, it can also lead to unhealthy coping mechanisms and other types of risk-taking behaviors, such as drug use or excessive alcohol use, all of which we know increases the risk for both intentional and unintentional injury. So turning to prevention here, addressing the social determinants of injury is known as primordial prevention. And primordial prevention essentially focuses on improving daily living conditions by modifying and preventing the emergence and establishment of factors that are known to increase the risk of disease or injury. And evidence really shows that this reduces incidence and severity of injury and makes individuals more receptive to injury prevention initiatives. And this image here is from the ASIP Social Determinants of Injury report, and it really visualizes the need to incorporate a range of interventions, recognizing that interventions that address the social determinants of injury will have the greatest impact. And traditional injury prevention activities focus on the 3 E's. And you may have come across this before if you do injury prevention work or work related to that, but those are education, enforcement, and engineering. And combining one or more of these interventions is shown to provide a more effective approach to injury prevention. So if we look at the example of cycling safety, for example, helmet use is an example that fulfills all 3 E's. A helmet is an effective engineering intervention, effectively reducing the risk of severe head injuries by 60%. And providing education on the risks of cycling without a helmet and the safety benefits of helmet use can result in families and children wearing a helmet correctly when they do ride a bike. And lastly, coupled with enforcement, we see legislation in many regions of Canada requiring helmet use. And this type of work where you see these three things coupled is an important way for increasing knowledge and self-efficacy among individuals to adopt and maintain certain health promoting behaviors. However, what the 3 E's don't consider is the needs of all populations. So communities and individuals must have fair access to resources and opportunities that facilitate that positive physical health outcomes, but also those positive social and emotional outcomes as well. So if we look at our example of cycling helmet use and safety again, a significant, you could argue that, several equity gaps exist in this example, but one that we kind of come across at Parachute pretty frequently is that helmets are not designed for use with a head covering, leaving many families and young children who wear hijabs and other religious head coverings excluded from this protective benefit of a helmet, and potentially also subject to a fine for not wearing one. And really the bottom line is that injury prevention strategies need to be considered within the reality of people's daily lives. So, and this is the missing equity piece that I was just referring to. All right, so I'm going to now turn it over to Steph, who's going to talk about some of our work developing some resources that we later used in a kind of case study that we'll talk about.
So the remainder of the bulk of what we're going to speak out in the remainder of our presentation really focuses on how we've applied some of these principles, particularly to providing, education and information to parents and caregivers for children up to age of 6. And Claire's going to speak to some of our current work, but before that, I want to speak to a little bit of the foundational work we did several years ago. So we did this foundational work with the Community Action Program for Children and Canadian Prenatal Nutrition Program. And at the time, we were developing a child injury prevention course for anyone working with families and developing accompanying resources that they could use for education and the work that they were doing. These practitioners identified need for simple images and messages. And so we developed these graphic images and key messages for parents on a number of child safety issues that affect children up to the age of 6. So particularly falls, burns and scalds, drowning, poisoning, motor vehicle injuries, playground injuries, and suffocation. We considered the issues as well as ages and stages. And so in developing this, the intended audience we were looking at were parents and caregivers with some particular characteristics. So those who are new to Canada, those who may have low literacy skills, who may be lower income, who are young, particularly teen-aged parents, and then also those identifying as Indigenous. Next slide, please. So in this part, we did review existing best resources. So there were already some great pieces out there, including A Million Messages, which was being implemented in a few provinces, including Saskatchewan at the time. We also did some needs assessment with the practitioners that we were working with, but a really important component was focus testing and information sharing with parents in the audience we were hoping that these resources would reach, and really understanding their specific needs and desires for receiving the information and what would make the information resonate. And the particular participants in the groups that were worked with, and we want to acknowledge that the participants in this case were female. They were groups with there was a group with specifically Chinese moms, Indigenous, some that were new to Canada, and also teenaged. And of course, there can be intersectionality among these different characteristics that I'm mentioning here. And so the concept was focus tested, and really the concept that was developed to this point was the idea of showing both negative and positive messages. And we'll talk a bit more about what that looks like. I'll show you an example. So we're not talking in the abstract here. Next one, Claire. So what were some of the things that we learned from this information sharing and the, some of the value that really came out of connecting with these communities and learning from their experiences and what they wanted to see and hear. So there was a desire to see negative images of what could go wrong with injury. So not just seeing a positive, often we talk about just, positive messaging, we should tell people what to do, but they also wanted to see what happens if you don't do those things. But they didn't want that image to be overly negative. They still wanted the overall message to be empowering. We found out simple things like in terms of denoting positive and negative outcomes. They didn't want happy faces and sad faces. They wanted X's and check marks and these types of things to appear in the messaging and in the graphics. They wanted in images, whether the outcome was shown to be negative, so an injury occurred, or positive, the injury didn't occur. They wanted images to include parents in both scenarios, so where that was appropriate. Obviously, that's not appropriate if we're talking about a lack of supervision, but if we wanted to reinforce that it's not that you're a bad parent, it's not that you're an absent parent, these things can still happen when parents are around, but we want to empower with what you can do when you're with your child to prevent injury. Next slide. So those were kind of feedback on the types of things that parents wanted to see and hear. When we actually kind of reviewed the concepts and the images and messages that were developed, those participating in the focus groups really did feel that they, or demonstrate that they understood the message that was coming through, that this image and message told me what I could do to prevent image. And that also what was really important is the message wasn't entirely reliant on language and written word, that the imagery was strong enough and specific enough to convey the message if without the wording if needed. So just looking at a few examples of the concepts that we're talking about, and I'm just going to give a few quick examples. So here is one on the subject of kitchen burns and scalds. So we can see in this, we have kind of a negative outcome. Your child could be burned. This is what could happen. But here's the positive of what we can do. Let's, we're going to use these appliances still, but let's push them out of the way. You can see this example of the parent is still present. The parent's not absent. They're not a bad parent, but this incident could occur. So here's the empowering image. Next one, Claire, please. So this one is a drowning image. Now this one is particular to, in the first one, you can see there's no parent because the image here was about the parent being away. But again, we can see the reflection of the negative and positive outcomes of this scenario. And the last one is about sleep safety. And again, just another example of that negative image of what could happen and the positive, simple, empowering language. And also, with that negative image, it shows the outcome, but it's not, graphic and startling and upsetting for a parent to see. So that's kind of where we started and some of the learnings that we gained in terms of messaging and targeted imagery. And Claire is going to speak now to what we're currently doing to move this type of messaging forward right now.
Thanks, Steph. Yeah, so we have now incorporated some of this messaging into developing an injury prevention program for families with children under the age of 6. So a little bit of background, Parachute was approached by an Early On center requesting an online injury prevention workshop for families in Toronto. And Early On sites are sites that provide free programs for families and caregivers of children from birth to 6 years of age in Ontario. And they are very welcoming sort of drop-in spaces for families and parents and caregivers. They provide a lot of child-friendly activities, workshops, and opportunities for families in the community to connect. And at the time, we were in the midst of the COVID pandemic, and early on sites were delivering programming online, and many experienced gaps in programming they could provide because many public health nurses were seconded to COVID response efforts. And families were also, navigating very different and I'm sure in many cases very stressful routines. And we were also seeing families and children spending a lot more time at home, sometimes unsupervised in response to public health restrictions. And interestingly, some studies looking at data from this time have shown that certain injuries did increase, further strengthening the need and response to provide this type of education and reach parents in need. So to just confirm interest across a couple of different early on sites, we did reach out to a few different early on centers and confirmed a need and sought funding through the Ontario Trillium Foundation to deliver a series of workshops. So we ultimately decided to focus the program on early ons located within and serving families living in Toronto's neighborhood improvement areas. And neighborhood improvement areas are priority neighborhoods of Toronto that were selected based on how they fare across 15 indicators measuring outcomes related to economic opportunities, participation, health, physical surroundings, and others. And there are 31 neighborhoods in total that have been identified as NIAs, and on average, they have more children, newcomers, and visible minorities, and greater socioeconomic challenges across a wide variety of issues, including things like housing and income as well. So we developed this program and we were so lucky to connect with some really enthusiastic and engaged early on coordinators and program facilitators across the GTA and working in those neighborhood improvement areas. And we really followed their lead in terms of delivery of the program and ensuring that it would fit well with the parents and caregivers that they serve and align well with the other types of workshops that parents and caregivers have expressed that they need and are consistently accessing. So we did a number of consultations kind of looking at the topics of most importance to parents and caregivers, language needs, and program delivery options as well. And there were a number of key considerations that arose from these consultations, and I'll just kind of quickly go through a couple of them. So early on serve very, very diverse communities, especially the ones that we were partnering with for this program. And they serve many families who are new to Canada or who have immigrated to Canada. And coordinators really expressed that there was a limited awareness of injury prevention, particularly among parents who were new to Canada. The original intent of this program was to provide an online workshop, but our consultations raised a number of concerns with this format. Given early ons had been providing a lot of virtual programming for the last 2 years in response to COVID, there were concerns about the accessibility of virtual offerings, particularly for families without consistent access to a computer. And especially for those who were new to Canada or whose first language wasn't English, it was felt that this sort of virtual format didn't lend well for really understanding if English wasn't your first language. And we also really heard from the early ons that creating a community space was important, somewhere for discussion and connection, particularly in the wake of COVID. And many early on stressed that their families live in rented and low income housing and apartments, which for us highlighted some concerns around particular injury issues like window and balcony safety, and also a concern around capacity to modify the space itself to sort of install those to make modifications to make the space safer. So with the guidance and input of our early on partners, we really designed a program focused on meeting the needs of parents and caregivers who were felt to be most in need. We had a very diverse audience with many immigrant and newcomer families and limited understanding of injury prevention. So it was decided to deliver an educational workshop focused on preventing the most serious and fatal injuries that can occur at home, at play, and on the road. And the presentation focuses on delivering key injury prevention education that is age appropriate by encouraging parents and caregivers to think about kind of what we've talked about before in this age appropriate intervention piece. So thinking about what their child can do now, the risks that coincide with that stage of development, and how parents can keep their child safe. So we used the images from the child injury prevention course that Steph showed in the presentation and in the handouts that we developed. And these handouts were guided by sort of identified resource gaps that the early ons flagged. And we ensured that we had a really sizable translation budget as well to work with, because we knew we wanted to translate the resources into languages that early on identified their parents and caregivers as speaking. And this representation visually of the images and with the languages was really an important component of this work. So the next sort of solution that we worked on was regarding barriers to accessing virtual programming. We decided to pivot the workshop to be an in-person workshop. That felt a really crucial pivot for this program. And we also ensured that childcare could be offered, and that the workshop included a number of group activities and made time for a lot of discussion and questions at the end. I'm going to attempt to speed up a little bit here, so forgive me here. Lastly, to really complement the education that this program provided and to meet the needs of our audience, we felt that it was really crucial to provide safety equipment to the parents and caregivers at no cost, as well as clear instructions on how to install and use this equipment. So we specifically chose equipment that aligned with the education and the evidence and would be easy to install, so renter friendly and easy to sort of install and take out without impacting the space. And we provided all of the instructions on how to use this equipment in multiple languages as well. And we know that childproofing is one aspect of injury prevention that is very well supported by the evidence, but there are numerous barriers for low SES families. And the bottom line for us really was that, providing education alone isn't going to make a difference if the bottom line is that families simply cannot afford the equipment that is proven to, reduce serious injury. We also provided each site with ample equipment and resources to provide to parents who didn't attend the workshop, but who may access the early on for other services. It was important for us to recognize that there may be other types of barriers to accessing a workshop like this. Work and other commitments are important, but psychological barriers for families, particularly those who are low SES, needed to also be considered, and they can impact how people choose or don't choose to seek out programs, free equipment, and additional assistance as well. This is just a quick quote from one of our early on facilitators who was really instrumental to helping us design this program. I also want to mention quickly that we did build in evaluation into this program. So we did formative evaluation with our earlier on staff with consistent review of the material as it was developed. They provided ongoing input on all program decisions. And we have a pilot presentation scheduled as well, upon which we'll sort of revisit anything that needs to be changed. And we also have a paper evaluation designed for participants as well. I also wanted to mention a few kind of key considerations and takeaways for us, really highlighting here that a coordinated public health approach is essential, really addressing the underlying factors of injury risk. We need to reduce barriers for those most at risk of injury, being very cognizant of the impact of SES and other barriers to safety, and targeted educational strategies that provide that layered or multimodal approach are really recommended, as we really demonstrated in the early on project. So providing that education coupled with the equipment at low or no cost. And then community collaboration and leadership. So really making sure that communities are part of, and well understood to really design and tailor needs and identify and address any barriers as well. And very quickly, just wanted to mention some models and some other resources that might be useful to you in your practice. These are two models that do consider the social determinants of health and equity in injury prevention, and could be something to check out. And then some reports as well. And I will leave it there. And I think Robin will circulate these slides, so all of these resources can be accessed through the slides as well.
That was fantastic. Thank you. Sorry to rush you a little bit at the end. We want to make sure we have time to chat at the end too.
Thanks, Robin.
I have some questions I've written down already, so I'll try to keep mine to myself till the end as well. So Erin Beckwell is going to be our next speaker. Erin is a social worker, educator, and consultant who has spent her career working in the areas of health, education, and community development. Erin's work focuses on promoting accessible, inclusive, and trauma-informed approaches to care and support. Originally from Treaty 4 territory in southwest Saskatchewan, she and her wife have called Treaty 6 territory and the homeland of the Métis home for 20 years. Erin, please take it away when you're ready.
Thank you, Robin. Thanks to both Stephanie and Claire for a great sort of way to start us off. I'm just going to pop my slides up and see if I can get this to work. There we go. All right, so folks should be seeing my slides now. And I'm really excited, partly because we talk about trauma-informed practice or trauma-informed care a fair bit and more all the time, which is of course very exciting. I really find it fascinating though to look at things beyond what we often see as our direct practice or our direct relationships, and imagine how we could take these, I think, really helpful teachings and apply them to areas we maybe don't think about, like how we talk about injury prevention. So I was really up for the challenge of sort of stretching the trauma-informed teachings that we're often sort of, tossing around and thinking about them in the context of injury prevention, particularly for families and kids. I also am going to post, I know Robin will share the link to the recording and the slides. I do have some supplementary resources as well as my slide deck in a Dropbox folder. So you're welcome to go check that out as I talk if you're interested in some of that additional content. So one of the things that's really fascinating to me is as I was preparing for this, I was thinking back to when I first started sort of teaching and talking about trauma. And I actually had this quote at the start of every slide presentation I did, and I removed it a few years ago, partly because I had too much other stuff to cram into my slides. And it just kept coming back to me as I prepared for this, is that when we talk about injuries, one of the things that I think is interesting is to frame trauma as a form of injury. I think we often think about it a little bit differently than that. And I think it can be helpful to think about it as an injury that isn't only in the sort of mental health domain. It impacts us all over the place in our own lives, but also our relationships. And so it impacts communities, families, and of course, we now hopefully have some awareness or increasing awareness of the impact of that across generations and, just over the span of time in general. And so trauma, though, is still, I think, very largely misunderstood. And as a result, we tend to gloss over it or avoid talking about it or minimize it And ultimately, you know, this is sort of framed by Peter Levine in the context of a medical model talking about treatment. But absolutely, it's part of human experience that too many people don't get an opportunity to heal from or recover from, however they frame that, and access the supports they need to do that. And I think that's an important piece to just keep in mind as we're thinking about how to make sure children and families have opportunities to be as well as possible throughout the lifespan. And part of that includes trauma, which may impact how people think about risk, how people engage with information coming from folks they may perceive as authority figures, but also how people are making decisions in situations where there may be stress or other things that are impacting their ability to sort of recall information and make good decisions in a moment. So really quickly, and those of you who've heard me talk have probably seen this slide 4 billion times, but I'd like to start from a place of talking about how trauma is understood today. And this is my take on that through the combo of a whole bunch of different scholars on trauma, but also through lived experience. And we're walking alongside many people over the course of my professional life. And so trauma is triggered by an event, a series of events or a set of circumstances. And as I said, that doesn't have to be in your own life, in your own personal direct lived experience. Children we know can be born exhibiting symptoms of trauma or sort of primed for trauma if they're exposed to trauma in utero. There's genetic expression that links into how trauma shows up in people. And then there's also the very broad impacts on everything from health, education, you know, sense of safety and connection and community that can happen over history and over generations. And so we look at all of that context. And so it's the what happened, and what happened could be at a certain moment, which is that event. And I'm just trying to hide my, I'm getting blocking some of my text, and evidently it's not going to want to go away. We'll see if it disappears. Hopefully it will eventually. It's very strange. But there we go. Magic happens sometimes when we just leave things alone. But looking at an event tends to be a little bit tidier. It's not easier to experience, and it doesn't mean it has less impact on people. But an event is often something we can point to and say, at this time, in this moment, this happened. It tends to fit the way we'd like to try to cram our experience into cause and effect. That happened, then other things happened. So when we can point to a specific thing, it tends to be a bit more likely that we will have some sense that, oh, there's a connection there, or that others will be able to acknowledge that. Series of events, though, is where the complexity starts to come. And so series of events could be multiple unrelated events over time. It could be things all related to a particular thing. So an example I use from my own life, when I was in the 4th grade, right around this time of year, actually, my mom, my siblings, and I were driving in our truck home from the city, and we were hit by an impaired driver. And our vehicle rolled many times. And so that was an event that definitely could trigger trauma. And then our mom was taken to hospital. She was the most sort of seriously injured. And all the kids we were okay enough that we were sort of left at a stranger's house waiting for our grandparents to come get us. So we were left alone. We didn't know where our mom was. We didn't know what was going to happen to her. I was the oldest sibling. I was left to sort of care for my younger siblings. And that was another source of trauma. And then we went to the emergency room at the hospital. Finally, our grandparents took us, and they separated all of us into separate examining spaces. And I was incredibly distressed because my job that my mom gave me before she was taken away was, you need to stay with your sisters and you need to look after them. And so I was very upset because I didn't know where they were and I didn't know if they were okay. And so there were layers and layers of things. That's a series of events that's all connected in time. And for some people, though, it's things that are seemingly unrelated, separated by minutes, hours, days, years, sometimes decades. And then sets of circumstances are sort of what I often call the least tidy of these options. And that's more contextual. It's not something we can usually say, yeah, on this day at this time, this thing happened. It's just how life is. So sets of circumstances include living in a world that exposes you regularly, daily, sometimes, to structural racism, to discrimination. That is a set of circumstances that isn't something you can point to and say, that's the day this happened to me. So it becomes a little more challenging for people to conceptualize and wrap their head around, but it also tends to be erased and denied by society. So there's often a sense like, well, we can't see that, so it's not real, it's not a thing, which then creates sometimes additional layers of trauma because people are experiencing something that folks will not validate or others can't see in the same way. Sets of circumstances also can include growing up in a home where there's violence, where it's not necessarily about a specific event, although there may be certain days or times where there's things that could be fitting the description of an event. And in some people's lives, in some communities, there are many, many people who have all of these, that it's not just one, it's a mashup of everything. And they may not even be able to discern completely what's what, right? Did that event make that worse? Did that situation make that worse? And being able to discern that can really cause additional distress for folks when it's just so messy you can't pull it apart. And the thing that's interesting, though, is it's not those happenings that actually create the trauma. They create the context where trauma can happen. And so trauma has to be something that our brain and our, as part of that, our nervous system is assessing as actually or potentially physically harmful, emotionally harmful, and or life-threatening. And again, it may be one of these very dominant, it could be several of them or all of them at the same time, that, you know, all the alarm bells are going off. And one thing we know is if someone has a history of trauma, including intergenerational trauma or sort of what we often call epigenetic transmission of trauma. So say a parent who'd experienced intense trauma prior to a child being born, we can see an increased likelihood that a nervous system is going to say, no, this is not okay, we're in threat right now. It takes less and less to sort of set off the alarm bells in our body. And so then the third ingredient is the impact of it. And that's really often what we're talking about when we talk about trauma, is how it affects people. And so it can impact any aspect of our lives, and how it impacts people changes over time, typically. And that is because of where people are at developmentally, support we've maybe had ability to access, just life experience helps us start to maybe have some perspective over things, cultural and spiritual teachings and the perspective that may come with those, and relationships. And so one of the biggest things that can help people overcome the adverse effect of trauma is good, safe, consistent relationship. And so if people get that, it can actually shift things in a very significant way. But if people aren't getting those supports they need, or they don't have opportunity to explore, how did I come to interact with the world the way I do? How did I come to experience it the way I do? They may continue to struggle in basic functioning, in social relationships, mental health, and that includes like cognitive functioning. Trauma is notorious for messing with people's memories, their ability to process information, their ability to make decisions, which is, I think, why it's particularly relevant when we talk about injury prevention. But it also impacts ability to regulate our emotions. And so be able to stay in control, relatively calm when there's something very, what we perceive as very threatening or, you know, sort of scary happening, especially to a child. And some people may shut down, and that may mean they struggle to act. Others may escalate and sort of get heightened. and struggle to keep calm and, you know, sort of be connected in with things like impulse control and other executive functions. And then it can impact people in very profound physical ways, which can include all sorts of symptoms. Very commonly, though, we see folks with chronic pain, and that can be a tough one because it can be incredibly disabling and really impact people's ability to function, and can also be related to people's sort of pain tolerance, risk tolerance, and so on. And we also see folks with all sorts of other physical health issues that our medical system is often quite ill prepared to even conceptualize, that physical health issues can be caused by a trauma that has roots that go back potentially before a human was born, right? That we just, it's not there yet. And it's a really challenging piece for folks who are experiencing this. And then of course, our spiritual well-being, our sense of order in the world, and you know, that there's a sense of connection to something beyond us. And a lot of folks will go through some pretty intense spiritual questioning, especially if they had beliefs that brought them some comfort prior to things happening. That can be disrupted and be a significant challenge for folks to navigate. So trauma is really about coping. When we have better coping capacity, we are able to experience things that might be seen as life-threatening or harmful, and not go into that sort of all bells alert, we need to sort of hunker down. We may be able to say, okay, but we can cope with this. And that's when there's a buffer sort of zone where things might not have to turn out as, you know, lifelong adverse effects of trauma. But for many of us, especially when we're kids, we don't have that coping capacity. We might feel that this is too much for us to cope with at once. It might be coming at us too fast. We can't process information that quickly. It might be too soon, and that could be too soon developmentally. It could also be too soon after something else has happened, that we have a diminished capacity. But then not enough, that perhaps we've had not enough support, not enough validation, not enough, even looking at things like not enough of our survival needs are met, which means our capacity drops, right? So if people are struggling to figure out when my stomach's not going to growl anymore and going to have enough food, their capacities drop to cope with anything that might come at them, including a situation where there could be a risk of injury, or there could be a safety issue that needs to be, you know, sort of addressed or thought about, even acknowledged. So when I talk about trauma with people and communities, I often am talking about coping. That one of the things we can do is help people have better coping strategies, more of them preferably, so that when they are in situations that will come at them and feel overwhelming, their nervous system is saying, hey, I don't know if we can cope with this, that we can sort of respond with a, yes, we can. We've got some techniques. And so that's one suggestion I have, is to sort of think about injury prevention through that lens of overwhelming capacity to cope. So how do we bolster coping capacity and provide perhaps some acknowledgement that that could be one of the ingredients that is part of either making decision about risk or how parents see their children's risk and safety. So really, trauma isn't about what happens. It's about, you know, what happens when we don't have somebody to say, wow, that was intense. I can imagine that was distressing for you, or sad or scary or whatever is going on. And then to say, like, do you need some help, or is there anything you need right now? That's really the sequence of things that people need to not head into that sort of potentially lifelong impact of trauma. And so Peter Levine talks about it as a highly activated, incomplete biological response to threat. And so it gets frozen in time. It just kind of sits there if we don't have something to kind of jar it loose and start to melt that freeze. And that can be a really tough thing to negotiate and navigate in life. especially when it comes to parenting or caregiving for children, is often people will find their trauma responses get activated by being around kids that they are responsible for, especially because kids often don't allow us to be in control fully as adults. They tend to, have different agendas than grownups do. And so that can make it difficult for the grownups around kids. If we're providing care to children as our job, or we're parenting kids or caregiving for kids in our lives, that can be something we may want to sort of just reflect on, is how much that might be showing up when we're really struggling in some of those caregiving moments. And often one of the things that folks will talk about is if their child has one of those sort of near miss incidents and they panic or shut down, or, just like I've supported folks over the years who said, I would never hit a child, and when I saw my child do something they were going to get hurt, or that, it could have been catastrophic, I did or thought about doing, came very close to doing things I never imagined I would do. And very often that's about some type of trauma response that isn't within our full conscious control. And so we also know, though, much like when we look at injury data, we can look at trauma and see that context matters, right? And so our past experience, our culture, our gender, our race, our own resilience, and sort of how well who we are and how we sort of are oriented to the world fits with a more dominant kind of narrative of what we should be. So if we're pushing the limits or making others uncomfortable in some way because of who we are, that will impact how we experience trauma. And that means people who do tend to be seen as on the fringes of society or challenging some kind of, dominant or widely accepted story about what people are supposed to be, are more likely to have trauma and are more likely to also experience injury. So there's a lot of interesting sort of intersections here. These folks are also less likely to access the support they need to recover and heal from trauma, and so have less access to the supports that could make much of this improve or reduce risk if we're thinking about it specifically with injury. And so that's an important piece to be aware of, is that access to and connection with safe, accessible, and appropriate supports. And that isn't just paid helpers, health services. Those are important. Support can be much more broad for folks, though, and maybe they feel safest with a community member, a neighbor, an elder, not necessarily the paid helper who's got the credentials behind their name. And yet we live in a world that tends to sort of prioritize those folks' value and their, that everybody needs to go to counseling. Not everyone can, and it's also not helpful for everyone because it's not always accessible or culturally responsive or inclusive. And so those things are also important to remember here, is that, yeah, it'd be great if folks could sort of resolve or at least understand some of their trauma and how it might be impacting their own assessment of risk, or how they parent, or how they care for kids, or maybe who they were as a child, which is also part of the story, right? And not everyone has the privilege of being able to connect in with those types of supports, which is one of the toughest things about this, is we can understand trauma, but so far we don't have a really good system to get people connected in with safe enough helpers who will really support them as they work through stuff. So really what this does is it shifts us away from connection, which is how humans tend to be. Most humans are wired for that connection, and it moves us to protection. So we prioritize safety and protection, or our understanding of it, our nervous systems read on what is safer, which isn't always what makes sense in the here and now. So I won't go through all of these, but you'll have this in the slides. So this is where fight and flight comes in. We also talk about freeze and fawn now as well. So these are different patterns of protection that our nervous system heads into when we feel like we're under threat and we need to go into that protective mode, which means we cut off, in some cases, our ability to connect with others. So that might be happening between a parent and a child. It might be happening between whoever's putting out messaging and who's hearing it, and where there's a sense of, no, I can't hear this, or that doesn't work for me right now, because I'm in, you know, a state where I am not in full conscious control over what's going on. And I'm going into, I often call it a more autopilot response, which is a nervous system sort of taken over saying, no, we need to prioritize survival right now. We don't have time for logic and reason and thinking through consequences and risks and, you know, remembering what that public health campaign said last week. We're just in like fight for your life or run for your life or just curl up in a ball and hope it's over soon. And that's where we go. Some of us will go into that, what we call fawn, which is, I'm going to basically people please my way through this and try to keep everybody happy to make the people I care about, including myself, feel safe. And it, you know, with injury risk, it doesn't really work that way. So we see some collision. And so once people go into a trauma state where it's triggered in their brain, their nervous system, trauma sort of overrides their logic, their reason, their decision-making, their impulse control. And so that becomes a significant factor when we think about injury prevention communication. You know, messaging is, if someone has a history of trauma, and we know there's greater likelihood of that among folks who already face many challenges in accessing information and acting on it, then we're looking at an additional challenge here, where we then see folks may not be in a situation where in the here and now they can just make the right decision and do it. They may not be able to access that information because they're in that survival mode, and their nervous system is telling them to do other things. So the way trauma-informed works is we do universal precautions. So we don't need to know there's trauma present. We assume it's there. That especially if we're working with communities where we know there's experiences of stigma, discrimination, you know, racism, homophobia, transphobia, et cetera, we know that there's higher rates of trauma in those communities, but there's trauma everywhere. Service providers, parents, kids, it's part of human life. So we go in not needing to do some specific assessment of how many people in this audience I'm trying to reach, whatever the audience looks like, have trauma. We just go, you know what, odds are pretty good. There's a large number of people who have trauma experience. We don't know what that looks like, but let's plan that into the way we talk about, you know, injury prevention. And so one of the main things is a trauma-informed approach prioritizes safety. So it acknowledges that people are in that pattern of protection and sort of goes there with them and doesn't say, well, you need to be here instead, right? You need to get over here where we're trying to talk logic and reason and, you know, get you to do the right thing. Well, we may need to explore safety a little differently before people are willing to go there with us. And so that means looking at safety beyond physical safety. We've started increasingly talking about things like psychological safety, very important, but really acknowledging that in order for people to stay in a place where they feel calm and responsive, so able to engage with the world as it is in the here and now, we need to explore how do we get people to feel safe enough so they can hear what we're saying and they can process and interpret that and how it applies to their life or the situation they're in, and they can act on it. And so that may mean acknowledging that sometimes when there's scary things happening, you may feel out of control. You may feel like you aren't driving your own bus. And that's often how it feels for folks, and they may not have a lot of understanding of what's happening. Like, whenever my child, you know, does something that I perceive as risky, I don't actually feel in control of what I do in response to that. Or if I'm trying to think too much about risk, I tend to get into a place where I maybe freeze and shut down because it scares me, and my brain and nervous system can't distinguish between there's an actual threat and we're preparing for the, you know, the risk of what kids do and what they're exposed to in houses. So being able to sort of think that through in terms of messaging is important. And that may just mean acknowledging it as real. And that's a huge piece for folks, is to have someone say, yeah, it actually is natural that sometimes when there's very intense or very stressful situations that have been part of your life, preparing for those and trying to anticipate those with a child or someone you're caring for can be really distressing. It can be triggering. And that's actually not a sign anything's wrong with you. Or sometimes it's hard to act upon information, even when you want to do the right thing. And just sort of putting it out there that happens sometimes. It's not, you're not the only one, because so often people struggle with that in silence and in isolation. They honestly feel like I'm the only parent, the only grandparent, the only caregiver on the planet who struggles with this, because who would struggle with making my house, my neighborhood safer for kids? And people will start to feel shame and guilt about that, and that doesn't help make better decisions either. So it can be a bit of a vicious circle. So really what people need to have is a sense of trust with whoever's communicating out information, whether that's an organization or an individual, and just remembering that even if it is sort of messaging prepared by organization, but then delivered by an individual, who that person is and how they present it will impact a sense of trust or not, reinforce that, maybe undermine it in some situations. That transparency helps, just sort of naming it, which tends to be a stretch in a lot of messaging, especially around sort of health issues, is just acknowledging that it's not always perfect. And in injury prevention in particular, it's tough because there is a right and a wrong. And, it makes some challenges with messaging, where the reality is people's lives often happen somewhere between right and wrong. And often people might be looking for, well, is there a good enough? And our messaging is, well, here's the ideal. This is the safe. This is the healthy. And that can make it challenging for folks who are like, what are you not saying about this? Oh, it doesn't always have to be like that, right? And then so there may be a desire for some transparency there. I loved hearing Claire and Stephanie talk about their process of sort of testing and engaging folks around, how does this sound for you? Is this a voice that you would listen to? Is this your voice that we're sharing out here? And giving people that opportunity, but then also facilitating some choices for people, which can just look like different methods of getting messaging out, rather than assuming, oh, like was mentioned before, everyone has access to the internet, everybody's on social media these days. And not necessarily. And really thinking trauma informed would be, well, are there particular means of communicating that might work better for people who struggle to engage because of a trauma response? I don't know, right? It's something just to add into the reflective questions, and then to really understand that trauma sort of informed is about connection, building the relationship, which, I think is critical when we're looking at awareness and education. And how do we help people feel like we see them? And not in a judgmental way, but in a way that's like, yeah, I see you, I hear you, and we're responding to what you need, or we're here for you, in a way that feels like a safe enough connection, which may mean changing the language you present in, or the imagery you use, and so on. And so I have a few examples. I'll just give folks a little heads up. Try not to pick gory ones, but just knowledge that this, I think, is an interesting one. And I didn't source them, partly because this isn't about shaming or, sort of naming. This is a bad one. But they're so common in this type of work. So often the one thing is, safety first messaging. What kind of safety are we talking about? Because for folks with trauma histories, it will be survival safety first, which might not always align perfectly with the type of safety we're thinking about. Hopefully it's pretty close, but there may be some sort of misalignment there. And it may be that it's sort of whatever sense of safety that person needs to stay as calm as possible first, and then the other stuff second, which could be a critical distinction. But a lot of the messaging, I think very well intentioned, but be alert. That's one of the things when folks have trauma stuff they're trying to manage, they may notice gaps in their awareness of what's happening, especially if there's a high stress situation or there's been a history of that. There may be a challenge with alertness. So it's like, if it's all about I have to be alert in order to help my child avoid injuries, they need to be alert. Those may not always be attainable for people. And so really just being aware of that, don't become breaking news, which I think sometimes a lot, like we've started to make more of a shift away from some of the language it's like, yeah, you don't want to be embarrassed by being a headline. Often what's tied up with trauma is shame, right? And so we just need to be so mindful that we're not inadvertently creating a situation where someone's like, yeah, it would be a spectacle, that would be awful. Not, we don't want you to get hurt, we want you to come home safe, those sorts of things. But even really basic messaging around preventable injuries are the killer of kids. I get the reasoning behind some of the really impactful, very direct language, and there's a place for it. But just being really mindful about some of that language that could be quite triggering for folks. And then the imagery. And so I've included a few different images that may seem very appropriate, and in some settings they will be, and in others they may actually cause folks to sort of disengage from the message, just because they could be seen as triggering. So it doesn't mean don't use them, it just means be thoughtful in when and where they get used. So there's a bit of research coming out, including some that was pulled together by the Prevention Institute. It was specifically about FASD, but looking at things like risk-taking and trauma and the connections there. And as I mentioned multiple times, accessing our reason, logic, that frontal lobe stuff, executive functioning. When we're in those trauma sort of states, it's pretty tough. Some people impossible to go there. So folks also like to seek out any way to feel like they're in control of things, especially situations that are very triggering and difficult to regulate their emotions. I'm just going to hop ahead a little bit really quickly because I know my time is up. But I also want to mention, if folks want to reach out to me after the session with specific questions about your campaign or your education session, please feel free to do that. My email address is here for that reason. And you're welcome to chase me down if you want to ask questions about any of these examples I provided towards the end.
Thank you so much, Erin. That was great. We do have a few minutes here for some questions. If people want to either pop those in the chat, or you're welcome, you should be able to unmute yourself and ask a question verbally if you like. And while we wait for questions to roll in, I am just going to pop a link to a survey for your feedback on this webinar, which will also come up when the webinar ends for you. I have a question if everyone's going to be shy. Claire, I was really intrigued when you said psychological barriers. I wondered if you could talk a little bit more about kind of what you mean by that and what that term encompasses.
Thanks, Robin. Yeah, I think with respect to that type of, recognizing that not everyone may feel capable of attending a session dedicated to injury prevention at that time. And I think, Erin, I welcome your thoughts on this as well, but I think that that was a huge piece of kind of designing this workshop, and also the way that we try and make our resources available online as well at all times is, you know, ensuring that people can access this information when they need it, in kind of and in a space that may serve them best. We did intend on providing all of the early ons with, you know, packages to provide to people attending the workshop like itself, and then we provided tons and tons, or we are going to provide tons of material and equipment for them to kind of provide to people at their discretion, also translated as well. So if people want to take that home and digest it there and also share it with other family members, then that's kind of our hope there. That yeah, people might not feel ready or you know, particularly interested in participating in that type of workshop. It might be stressful, or kind of present some things that could be you know, difficult to hear. But Erin, I'll turn it over to you if you wanted to also, you know, jump in on that at all.
Yeah, thanks, Claire. No, I agree that I think so much of those, and so many of those psychological barriers are, you know, do I have the capacity in terms of my own emotional well-being, my mental health, to engage with this topic right now? And rather than making that a yes/no question, making sure that people have other ways to circle back. And I think it's been interesting as I've sort of learned and unlearned, even looking at the impacts of sort of colonial ideals on values, on how we educate and share information. So often it's, no, you attend this session, and if it's important to you, you make it a priority. If this stuff matters enough to you, you'll be there. And we know that isn't how humans work and not how life works. So just being open to posting recording links and making various formats available and sharing resources rather than sort of gatekeeping access to a lot of that material, I think really does give people that flexibility they need to access when they're ready, which may mean we're not missing people who can't, you know, maybe they have anxiety and showing up at a parent education night isn't going to be their thing ever. So does that mean they just don't get the info, or does that mean we find other ways to engage people who aren't going to come to that in-person session or sit through a Zoom session or whatever?
Thanks, Erin.
Thank you. I appreciate that. If there's no other questions, we're probably okay to wrap up a little bit early. Although I rushed you both through your presentations, I shouldn't have done that. Thank you everybody for being here today, and thank you to Erin, Stephanie, and Claire for taking the time to share this with us. When you close this window, you will be directed to a link where you can complete a short survey evaluation of this session. Completing these evaluations helps us to create programming and resources that support you in your work, and we appreciate the time that you take to complete those. And I think that's it for today. Thank you again, everybody, for being here.
And thanks, Robin, for bringing us all together.